So good day, friends. This is Dr. Bob Hamilton, and you have tuned in today to the Hamilton Review, where kids and culture collide. So before we start our show today, I just want to say thank you to all of you who have tuned in. It means a lot to me. I know that every one of you are out chasing kids, running errands, trying to feed your family, all the things that human beings do, and you're busy people. And the fact that you take even a minute and tune into the show means a lot to me. So thank you. If you like what you hear, I hope you do. Why do I hope you do? Because I bring a lot of amazing people in front of you, my audience, on a weekly basis. So I hope that you're happy with what we're doing. And if you do, please share it with your friends and neighbors. Everybody, we're building an audience, not for me, but the beautiful people that I have on. And today's no exception. So today, it's a pleasure to welcome to the Hamilton Review, Dr. Blaine Leeds. Dr. Leeds, welcome to the Hamilton Review.
Dr. Bob, it is a pleasure. Thank you so much for having me on, and hopefully we can bring a little value to all your many, many listeners out there.
Amen to that. So listen, Dr. Leeds, who is he? Well, he is a general dentist. He's licensed in 12 states. He has recently moved back to his hometown, which is Clarksville, Arkansas. He is involved with a lot of, what can I say, braces, clear braces. He's going to talk about that. He's written a book. We're going to talk about it as well. But before we get into all of your many accomplishments, Dr. Leeds, I'd like to have my audience hear from you. So we're going to back up all the way back to the day you were born. Maybe not that, but you can. And tell us a little bit about your story, your journey, what brought you to the dentistry field, and why you're doing what you are doing today.
Happy to. I actually laid in a bassinet. I don't even people still have bassinets anymore. I mean, as a pediatrician, you would know this.
No, bassinets are the go-to initial sleeping, little Moses beds they call them, but that absolutely.
Well, I laid in one of those about 4 miles from where I'm sitting today on a dirt road at the foothills of the Ozark Mountains here in a little town in western Arkansas. And never knew growing up that I wanted to be a dentist. I thought I was going to be a pediatrician, just like you in ninth grade. That's what I set out to do. And one way or another, I met a guy named Fantastic Phil Dowdle, Dr. Phil Dowdle, who was the head of admissions at the University of Tennessee Health Science Center back in 1991. I was the president of the student body at a little land grant institution not far from here called Arkansas Tech University. Fight on, Arkansas Tech. Now over 14,000 students, the third largest school in the state of Arkansas.
Wow.
But, went to school there, got a chemistry degree, was trying to figure out what I was going to do. Thought I'd be headed to medical school, looked at some chemistry opportunities, PhD chemistry stuff too. And, you haven't lived until you've had 13 30-minute interviews with PhD chemistry professors. That was a long day.
So did you sleep through them, or were you actually awake and alert?
I somehow stayed awake, but there was a lot of bubbling Erlenmeyer flasks and the like, all day long. But so ended up going to dental school. My dad was a mechanical engineer, worked for other people most of his life, ended up having his own company. But he was like, son, why don't you look into healthcare? You can be your own boss. You can come back here and live in Clarksville if you want to. And I liked my hometown. My parents, we were really poor, but we thought we were upper middle class when I was growing up. So my parents put us in the pickup truck and drove us to Detroit and St. Louis and Dallas and Florida. And we traveled some. So I knew that, metropolitan areas were nice places to visit. I still have a place in Nashville, which feels like my hometown and Music City. And, but I visited enough large towns to know that I wanted to practice in a small town. I wanted to raise my family in a small town, a small college town, beautiful little town here with the University of the Ozarks, which is famous for Helen Walton, Sam Walton of Walmart fame, the founder. His wife, Helen Robson Walton, was a student here at the University of the Ozarks back in the day. Beautiful little liberal arts school, about 800 students, just a couple minutes from where I'm sitting today. Yeah. But so got involved in dentistry. I was practicing general dentistry in my own physical office that my colleague and I, Steve Fisher, kind of built together. Steve was 16 years my senior in the profession, and we had a wonderful practice with thriving hygiene. And we were in a small town where we were a one-stop shop. We tried to do everything. and did do that for most of my career, and then never thought I would practice anywhere but Clarksville, Arkansas. That was my life goal. And Steve and his colleague J.R. Cook ended up purchasing my practice from me about when I was about halfway done with my career. So I was like, okay, what am I going to do? Bought another small practice not far away. And then in 2017, I merged that with another group, 2015, I should say. And then the clear aligner orthodontic folks came calling in 2014. And once we had FaceTime on a phone,
Yeah.
I knew that that was going to change healthcare forever. I knew that patients who, maybe their child just needed a little bit of antibiotic, or maybe, something, it was a chronic thing. They didn't want to drive in LA traffic, all the way down, to
Yes.
on the 5, to get over to where, to Santa Monica. So they would be using telehealth. I'm sure I've got my highways wrong. We don't want to get into an episode of the Californians with
Yeah.
Fred
No,
Armisen.
you're doing fine.
But anyway, so I if you're sitting down in Battery Park and you're a Wall Street whale, you don't want to go to the Upper East Side and sit for 2.5 hours at the endodontist to find out you're going to get antibiotics today and come back in a month. So we knew that this is going to make dentistry, medicine, physical therapy, pharmacy, everything more convenient. And so I built an app called Smile Finder. And the app would have worked great had I known anything about venture capital and how to raise money, but I didn't know anything about that, and so I didn't ask for enough money. Otherwise, you and I wouldn't be talking now. If I'd asked for $30 million, I probably would have gotten it. But I would, I thought $500,000 was a lot of money at the time, so I was asking for that. And anyway, we fizzled out for lack of funding, and then Smile Direct Club said, "Hey, Invisalign's investing in us. You're an Invisalign provider." I was one of the first 170 general dentists in the United States to get certified to do Invisalign back in 1997.
Wow.
And so, it was pretty cool to be in that room that day and start and see some of these things that were, these advances that were being made in our profession. And it's true of pediatric medicine as well. But, every month there's a very cool piece of technology that comes out that makes my life easier, makes it easier for my patients, my staff, my team members, to treat people. And, the technology that's out there in medicine, what we're doing with the AI, it's crazy, crazy times we're living in a good way.
Yeah,
And
no,
so,
I think that you're absolutely right. I think that, AI in particular, we'll see where that leads us in the medical profession, because no question that will be an adjuvant. That will help us out. It'll be hopefully a friend and not a foe. We'll have to see how that works out. But I'm kind of impressed that you were back in 2014. That was a decade ago now, Blaine, and you were a visionary. If you saw that and you realized that, you were a smart guy right there. And the fact that you got involved in Invisalign such an early on was also very wise as well. So you've been doing this. Invisalign works.
it does work. Absolutely, it works. And it was invented by non-dentists, right? These guys were in the Stanford MBA program, and this was their idea. It was like a thesis for their MBA, and they figured this out. A way to move teeth by making sequentially different plastic aligners that put pressure on the teeth in certain ways, and it does work very well. They've continued to make advancements in the technology. I've even been able to meet the gentleman. His name is Dr. Locke Fan. He works for a company about 5 hours north of you, up in Fremont.
Sure.
5.5,
Yeah.
with a company called OrthoFX, and they make fabulous aligners. They make the only FDA cleared nighttime aligner. They're the most flexible, most comfortable aligners out there, and a company that I'm just partnering with to start doing some of my first cases with them. But Dr. Fan likes to make these aligners better all the time. And he made the first aligners with Invisalign back in 1993, 94, 95. And now he's with OrthoFX making these aligners stronger, softer, more comfortable, more flexible, and able to expand the human palate.
Wow. Okay.
So
We're going to talk about that, because this is something that I think that you are an expert. By the way, Dr. Leeds is also an author, and I do want to talk about your book. He co-wrote a book with Brian Ferry, and the book is entitled "What Happens When Your Child Doesn't Sleep." So I want to just kind of talking about this whole idea of palate and jaws and just, sleeping in general. I happen to be, as those of you who listen to the show know, I am a gigantic sleep advocate, especially for kids who are growing. They need to sleep. But kids who have oral issues, who can't sleep, as Dr. Blaine and I talked about on our pre-call, we are what we call obligate nasal breathers, and especially when we're sleeping. So let me ask you a question straight up, Dr. Leeds. I will ask the question, namely the title of your book. What happens when your child doesn't sleep? I'll let you take it from there.
Okay. Well, what happens when adults don't sleep, to the X power, right? I mean, we know how we feel when we wake up after a night where we struggle to sleep. And, if we walk in and we see our kids in deep slumber at 6:45 and we're trying to wake them up to get the last little bit of homework done and shove some, sugar smacks. I can't call them that anymore. What are they called now? Some sort of my favorite cereal, King Vitamin. All right. It's 58% sugar by mass. Okay. So don't do King Vitamin. The FDA made them change the name. They made them from the correct spelling of vitamin to changed it where it was not, because there's nothing vitamin about it.
Yeah.
So we give them some sugar to try to help wake them up, and God forbid some pop or something like that, a classic Coke or something with their scrambled eggs. But when these kids are,
by the way, can I interject? Friends, do not do that. Do not give your child a classic Coke with their eggs. Okay, that's just a doctor's order. Okay, carry on.
Dentist order. Don't give it to them ever. Right? I mean, I'm a no. I mean, maybe a couple of ounces of Coke a day. Gosh, I don't know. I mean, maybe if it's our friends in Mexico, they make a better Coke, right? They use real cane sugar.
Real cane sugar, that's right.
I mean, I prefer that, to the corn syrup for sure. But these, I'll have parents tell me, my kid sleeps great. I can't wake them up in the morning. Well, that's because they just went to sleep. And so it turns out that what's causing our children not to sleep is, as you mentioned before, their inability to breathe properly through their nose. We should be breathing invisibly, quietly, effortlessly all the time through our nose, because that's the only time in our body, in the pharmacology of our body, when we secrete nitric oxide, and a little sensor back in the oral pharynx by the parasinuses. The air respired through the nose. First of all, I can turn profile for our YouTube watchers. You can see how big my nose is. When we breathe through our nose.
Wait, Blaine, never do that again, okay?
Let's try to think I injured someone over here.
Yeah, that's right. This PTSD over here.
Bob, okay. It's not that big. I mean, I have a strong nose, but I'm no Cyrano de Bergerac. I mean, let's be careful here. But it's the nose is, what is it doing? It's sitting up off of our face, right? It's got hair inside our nostrils. So we're breathing this air through the nose, and it's warming it to temperature. The hair is filtering the crud out of it. So the air comes into the oropharynx, warm to temperature. It's not like breathing through the mouth, where the stark air, unfiltered, hits right into the tonsils, right into the fissures of the tonsils, bringing bacteria and crud, and some of the bacteria that's healthy in the digestive process in our mouth gets dragged into the tonsils where it's not supposed to be. And so, we end up, what's happening when our child doesn't sleep? Well, they're not breathing through their nose. When they're not breathing through their nose, then all these other complications begin to happen. What happens when our child doesn't sleep? I'll tell you what happens. Bedwetting can happen. Attention problems can happen. Poor academic performance can happen. Big bags under the eyes, underdeveloped mandible can happen. Failure to grow and thrive can happen because we're not breathing through the nose. So that's most of the things that can happen when our child.
No, and we see this occasionally. We hear kids who are snoring. That's kind of a classic sign for parents. They kind of go, "My kid snores really, really loud," and we think, "Oh, okay, we got to check that out. Look at those tonsils. Look at the adenoids." But you're correct. I mean, if you're not breathing well, you're not going to be a happy person. And you're right. It goes for adults. I think I like to ask my teenagers the question, how much are you sleeping? They usually fib to me and not tell me the truth. But the reality is, if you're not getting a good night's sleep, you're not going to perform well, certainly academically and in your sports classes and all the other stuff they do. So this is important. So in terms of now you're a dentist. Okay. So you're looking at it from that perspective, and I interrupted you. So keep going.
Oh, that's okay. Well, like many other folks who start to delve in more deeply into certain areas of study, it happened because I became a patient myself, right? I mean, I've got a unilateral posterior crossbite, which means my maxillary teeth are inside my mandibular teeth, halfway around one of my arches. I've got a little palatal torus, a little bump on the roof of my mouth. It's bone where the tissue stretched really tight over the top of it. And I was told in dental school, I'm not sure what causes these. They're just kind of idiopathic. They're not anything to worry about. Just be sure to note them if you're a patient. They're only a problem if you're going to put a denture over them someday for a patient who's losing teeth. And it turns out now we know that bone continues to deposit if our palate is too narrow. And so we get these deposits of bone. You get them on the mandible too. You'll see little kids that have them. They look like Tylenols under your gums. It's just healthy overgrowth of bone.
Yeah.
But the reason is because that mandible is supposed to be wider and the palate's supposed to be broader and flatter, where the tongue can rest up behind the incisor teeth and stay out of the airway and off of our airway path where we're breathing. And so when we start as a patient, my wife, who could, we're here in Tornado Alley in Arkansas, she could sleep through an F5 tornado, right? And so she was hearing me stop breathing. And I started having elevated blood pressure, which for adults is, as a dentist, I started taking blood pressure on every patient at hygiene. It's just a nice service. Have the hygienist put a monitor on them while they're doing other things. You can take their blood pressure. It's just a real nice thing to do for all you dental folks out there and hygienists, that are listening, that have kids, in your daily work. Take blood pressure on patients, because dentists, because of the way dental insurance works, and we see our patients twice a year, and so we see them often, and we notice changes in their fingernails, or maybe they've got dark circles under their eyes. So we started asking patients, how are you sleeping? And they looked at us weird, for a year and a half, until we got everybody through the cycle and we'd ask them about it. And it's amazing what, a pandemic it is out there. This, speaking of pandemics, it's an epidemic for sleep, sleep loss. Sleep disordered breathing is a problem. We've made fun of snoring. You mentioned snoring. Some snoring is okay if somebody maybe has a nasal obstruction or something, but they're breathing through their nose and making a noise with their nose, that might be okay. But when someone they're open mouth breathing, trying to breathe, and with their head in a strange position, and they're making that classic, sound where they're struggling for air,
right,
that is no bueno, right?
Bueno. Yeah.
And what causes that is, the brain's saying, okay, we got to have more oxygen in the blood. Let's get more oxygen to the brain, to the muscles, to the heart. And we're not getting that oxygenated blood delivered fast enough. And so we start to see issues.
So what do you do?
So what we like to do is, and I did not do this, sadly, for the first 17 years of my career, because I was taught differently or not taught about it at all in dental school. And that's why we have continuing medical education, continuing dental education. We have to keep learning, because things change, as in our profession, both of us. And so, we started looking at, and this is why we wrote the book and why we're talking today, is we have to tell this story. This diagnostic stuff kind of lays in this chasm between medicine and dentistry. And we need to be communicating better across our two professions. And docs need to help the dentists understand things and vice versa. But the ADA said in 2017, American Dental Association, every dentist should be screening their patients for sleep disordered breathing issues in their office. Only about 10% of our offices nationwide do it. Only about 1% really understand it and know what they're doing. It's just like, the healthcare system's taxed everywhere. I mean, you can't get a hygiene appointment for 4 months in Clarksville, Arkansas.
Wow.
I mean, to go in and get your teeth cleaned. So, I mean, everybody's running behind, everybody's working faster. So when you go and tell a dental team, a hygienist, and a group of assistants, hey, we're going to add another thing to your treatment modalities that you're going to be doing here in the office. Everybody's looking, oh, here we go. So nobody wants to hear it, right? We're so busy. But when we're looking at underdeveloped jaws, that's what we treat in dentistry. And when I was in dental school, I was taught, hey, let's wait till they get to be 10 or 12 years old. If they have some teeth that need to be removed, we'll do that. Then we'll let them see the orthodontist and have braces. Well, when Bob, and I were kids, not everybody on our block had braces. Maybe 1 in 10 kids on the block had braces. And nowadays, it's everybody. So what's happening? Why are our jaws getting smaller? What is the anthropology that's happening here? Well, and this work goes back to Bob's bailiwick, which is breastfeeding. Moms are busy; they got to get back to work. Their maternity leave's too short. They're not breastfeeding long enough. They're pumping. Babies are using bottles. So there turns out that nursing, breastfeeding, is more of a chewing motion than it is a suckling motion. So it's toughening the gums, it's expanding the palate, the tongue is in the proper place when this is happening. So in sub-Saharan Africa, we see only a 5% incidence of sleep apnea, sleep disordered breathing in children because they, as you know, as a missionary to Africa, I stalked you on your website.
Yeah, it's true.
You don't see it as often over there because they breastfeed till kids are 4 or 5 years of age. And so,
yeah, they do. Yeah.
And we have a soft diet over here in the West. We start, I love my Gerber mixed cereal for my guys when they were little kids, but in other cultures, they hand them a carrot that's this long. They can't swallow it, but they can sure gnaw on it, and it toughens their gums, expands their jaws. And so it's soft diet. It's not breastfeeding. So now we're 4 generations in to this, physiology of an anatomy of underdeveloped jaws. And everybody that I look at all day long, it looks like someone took their index finger and thumb and just pushed their molars together. We've got all these, trapezoidal arches out there, instead of nice rounded, even bigger than the McDonald's arches, not even that narrow. Big, wide smiles is what we want. And then in orthodontics, for the last 20 years, we've been closing down all this space, and we've been doing retractive orthodontics with headgear. I see these patients and they come to see me, and they're adults, they're 40 years old, got a beautiful straight smile, but they're missing 4 bicuspid teeth that some orthodontist took out on them when they were 10 years old. And I put a CBCT of the head up on a screen, and I look at their airway, and it looks like on the profile view, it looks like a Starbucks coffee stirring straw, and it ought to be the size of my finger.
Wow.
And so move these people back toward their spine, and it's just, we've cramped that space down physically so much. But that's what we're looking at. And that's what we're doing. So when I found out about that, I was a CPAP patient. I'm still wearing my CPAP machine. The first night I put it on, it took less time to put on than did it put on a baseball cap. I was asleep in 15 to 20 seconds. I slept for 4.5 hours. It felt like I'd been asleep for a month. It was fabulous. And so I'm gradually correcting my own problem with appliances, but I'm using CPAP until I can get there. But the reason we wrote the book and the reason we're trying to tell this story is because we know we can treat children with great success because they're still growing and developing. So if their palates have for some reason narrowed in ages 2, 3, 4, whatever those reasons are, all we need to see these kids and help them is some photographs and a good medical history with their signs and symptoms and communication with mom and dad through telehealth. And we can provide an appliance that we can replace pinkies with as young as age 2. And we can start widening these palates, creating big, wide smiles, room for the tongue, and better breathing.
So you mentioned, okay, so the mandible is narrow, and you also have, and palates. The palate is also you say a high palate. That you mentioned that as well to me.
Yes. What happens is enamel is the hardest organic substance in the body, the enamel that covers our teeth. And the teeth have peaks and valleys on them. So when a child or an adult closes together, what we call occlusion in dentistry, the peaks on the upper teeth hit the valleys on the lower teeth, and it's locked in. And so, as a pediatrician, you may see a little child that's just grinding the fool out of their teeth. And what that child is trying to do, we used to think, oh, well, they're exfoliating some baby teeth. It's kind of normal for kids to clench and grind. No, it's not. That kid, I know now, after 28 years of doing this and after focusing on it for the last 7, when a child is grinding, they're trying to breathe. Plain and simple. They're trying to breathe through their nose at night, and their brain is saying, hey, let's slam these jaws together. Let's clench the teeth together because we need air through the nose.
More room.
And so these
That's
patients,
interesting. So you're, I mean, I sometimes, so you're saying that the grinding of the teeth is a strong indicator that they're not breathing well. Is
correct,
that's what you're saying? Okay.
that's it.
I sometimes say is postnasal drip, but maybe I need to rethink about that. So when you have, because I do, it's not a common complaint. It does happen, but when I hear that from patients, I should send them to a dentist. Is that what you're saying?
I would, because postnasal drip occurs a lot of times because the child's mouth breathing also,
Yeah.
and postnasal drip causes awful halitosis. You can smell that child when they walk in the, you can smell their breath when they walk in the reception area, right?
Yep.
So they're breathing through their mouth. So, and yeah, so here's the thing, especially it could be something else, but we need to confirm that their jaws are wide enough
Okay.
first.
That's good. And how do you actually take X-rays? Is that something how do you do that? Can that
No,
be done by inspection?
yes, just visual. You can look at it, and there's a guide, like for example, in adults, we like to see 41 millimeters across the palate between what we call the 6-year molars, or the maxillary first molars, which are, if you go to your canines and you go 3 teeth back, that's it. Everybody gets those teeth in when they're 6 years old. They don't replace a baby tooth; they come in behind.
Gotcha.
So,
Yeah.
yeah, and so, but those teeth, we like in adults across the palate, we like to see 41 millimeters there. It's very uncommon today. Almost everybody that walks in my office every day is too narrow. And if you could even keep these in your practice. The little dental cotton rolls, that we use to
Sure.
isolate things and try to keep stuff dry. Those things are 37 millimeters across. So it's a real quick measurement that we use. We take a, tongue depressor and some cotton pliers and stick it up in the palate and use it. If the cotton roll crimps, patient's too narrow. And
Yeah.
so, but with little kids, we're looking at just visually inspecting space between the primary dentition is huge. We want to see at least the width of a 10-cent coin between all the baby teeth. And we hardly ever see that anymore. We see kids, and I'll have parents say to me, "Oh, look at Tommy's teeth. They're so straight and they're so perfect. He's gonna do so good." I'm like, "Yeah, but just hang on a minute, because there's
Yeah.
big teeth coming."
There's
in the
crowding.
implants.
There's crowding coming. Yeah. No,
Yes.
that was actually the case with one of my children, and she had literally perfect little baby teeth. She was so cute, and then and then she got braces, of course.
Of course.
So you have been involved with a one of there are a handful of these things you mentioned. Invisalign by name as one, but you're also involved with a thing called tooth pillow. I'm curious. First of all, the name is kind of an interesting name. Usually, I think about when I think about teeth and pillows, I think about the good fairy. But you hide your tooth under the pillow, and the tooth fairy comes and in my day it was a dime. Now I think it's like $5 or something. But anyway, tell me about tooth pillow.
Well, inflation has obviously not hit your tooth pillow. I mean, your tooth fairy yet. Over here in the Midwest, it's $20.
20 bucks.
Yeah, it's $20. No, but
Okay,
tooth pillow.
remind me not to move back to Arkansas. Wow, that's
Jerome Powell, please hold down the inflation of the tooth fairy. But tooth pillow, we get either love or hate for this name, but it came from what the kids call their appliance, because they sleep with it. And so it's like a pillow between your teeth to keep you from damaging your teeth by grinding them. So we would say to the kiddos, "Where's your tooth pillow? Get your tooth pillow and brush your teeth and get ready to put your tooth pillow in." And so that's where the name came from. But what is a tooth pillow? Well, tooth pillow is not just a guide, not just an oral appliance, but it's a process where we educate moms and dads about things like myofunctional therapy, how to look for tongue ties and lip ties, because obviously if we have ankyloglossia, if we have the tongue trapped to the floor of the mouth with connective tissue, that needs to be diagnosed and treated as early as possible, because that child can't nurse properly. And they're very common. It's so funny. One of my colleagues, She's been a dentist for a long time. Her dad is a dentist in a major metropolitan area, very successful. Her mother is also a dentist. And she had a tongue tie, undiagnosed, a dentist herself, and the two parents, both dentists, and she didn't know she had one until she started treating patients and studying this. But that's something, to look closely at for sure.
No,
Early on.
I do that. I do that every day when I see a new baby, and I actually do. I do them. Do you call them frenulectomies or frenotomies?
Uh, I'm a frenectomy guy.
Okay.
That's what I call them. Yeah, frenectomies, and we usually do them. So you do them, you perform them as
All the
well.
time, every day.
Now,
Honestly.
so do you do them with laser, or how do you
I
do it?
just cut them. I cut them, and I mean the simple ones. I'm talking about the ones that are very anterior. The posteriors, you have to go to laser and you have to zap them a little bit more. But the simple ones, I basically nick them and tear it, and the frenulum. And you can usually. It's interesting. I actually did not believe in tongue tightness when I was first practice because that was what I was taught. And then I started speaking with the lactation consultants in my community, and they said, "Hey, Bob, this is real. You need to do something." And I began to I learned how to do it. And essentially, a lot of times after you do it, the mother will look at you and say, "What did you do?" This is radically different in terms of their ability to suckle. So
Yeah.
it does make a difference.
Yeah.
Yeah.
Well, and even adults, if there are adults that are listening out there, if they feel like they have a tongue tie or a lip tie, we had a patient that a friend of mine convinced this woman, you have a tongue tie, we need to treat it. Well, they did it for her. It's completely painless with a laser. She gets to the car leaving the parking lot of the dental office, and she calls on her cell phone and she's weeping. And the front desk person is like, "What's going on?" And she said, "For the first time in my life, I was able to turn my head and back out of my parking space because my neck muscles were not restricted." She had so much restriction underneath the mandible with this tongue tie that her sternocleidomastoid muscles would not function with full range. And so when she had her tongue tie released, she said, "I can move my head back and forth for the first time in my life." And so, we underestimate how significant these little anomalies can be for folks.
Yeah, interesting. That's crazy. Okay, so so the tooth pillow, basically, it is something that the kids wear at night. Is it an expander? Is it expanding their palate and their mandible?
Basically, what it's doing is it's preventing the musculature of the face from collapsing, like when we suck a pacifier or moving the cheeks in. It's preventing that from happening. And all it's really doing is allowing the tongue, which is the body's own natural expander, to do its thing. So the appliance is actually made by a company in Colorado called Vivos. It's a Vivos guide. That's the one I like the best, just because of the unique flexibility and rigidity that it has, so the kids can't tear it up, but it's just spongy enough for them to function into it. So when they're asleep, they can wrap their lips around it just enough where they can clench into it and breathe through their nose. But basically what it does is it trains the tongue to be up in the palate. And so that's just there's a little tag that's on the inside of the appliance that the kids can kind of play with it. And there's some exercises that we have them do. So we like to have them wear the appliance for about an hour before bed, like when they're doing screen time or doing homework or whatever, if they're 6 or 7 years old, if they, wear the appliance, then try to sleep with it. Most 2 to 3-year-olds, the first time we hand them something, doesn't matter what it is, they put it in their mouth. So it's almost intuitive to the kids. I don't even insert them on a 2 or 3-year-old. I hand it to them, and they put it in their mouth. And sometimes they'll put it upside down, and we'll show them what to do. But most of these kids, I'd say 70, 80% of them just take to the appliance really easily. They start wearing it. There'll be some kids that it's a real compliance issue. It'll take 6 months or a year for them to wear it properly. But even 15 minutes a day of wear of this device can really change things on these rapidly growing and developing kids. But so that's one aspect of what tooth pillow does. Then we call it a process because it's more than just an appliance, the tooth pillow itself. We like for the families to be using myofunctional therapy, working with dental hygienists who've had extra training to become a myofunctional therapist. all of my experts that I talk to, my mentors in this world of dentistry and treating this stuff, tell me that if you made them take away all treatment modalities and they could only choose one, they would all choose myofunctional therapy. So if you're a mom who's listening out there and you don't have access to an appliance, or you're in Montana and you're 400 miles from the dentist, find somebody that can do myofunctional therapy. It can be done via telehealth, and it can make a huge difference. So when you couple the tooth pillow appliance, counseling about sleep environment, is it too hot? 67 degrees, optimum sleeping temperature. Is it dark enough? Are we sleeping with the television or music on? So we help with sleep environment. We have an appliance. We do myofunctional therapy, and then through telehealth, the tooth pillow patients and their parents have access to doctors like we're talking now. So when they have an issue, they can talk to a team member or a doctor and get this treatment. And it's, half the price of what it would be in a dental office. And it's needs to be addressed early on. Like if you're listening and you're looking in the back of your Honda Odyssey minivan right now, and your child is sitting in the car seat and they're asleep with their mouth open and you can see their teeth and they're too tight and they're too jammed together, go out there and find yourself a dentist who understands airway, and they're out there, and they're sadly they're hard to find still, but there's a lot of us out there. There's 10 or 12,000 across the country that know what they're doing, how to help these kids.
So what about adults? Do you have a tooth pillow for adults?
We do. In fact, we have one that was FDA approved about 2.5 months ago. Vivos got FDA approval for an expansion appliance for adults. When I was in dental school, I was told you can't expand adults after their growth plates fused. You got to do surgically assisted orthodontics on these people that need expansion.
Right.
Now know that we can move the teeth, not tip the teeth. We can bodily move the teeth with an acrylic appliance with some springs that are placed in a certain spot on the appliances. There's about 33% of the population responds really well to this. Another 70 to 80% of these people can have a mild enough expansion, or rather significant enough expansion, where they get massive improvement in their sleep apnea by just a little bit of expansion. And so, for people who can't tolerate CPAP, which we know is 6 out of 10 folks who wear one, I try to tell people it's like batting 400 in baseball. I guess that's 40% is. I guess we're going to have to accept that as really successful.
No, that's in baseball. That's pretty darn good. That's very good.
Yeah, that's right. But not in sleep apnea. So we got 60% of people out there not breathing. So, but there's a way to do it. But back to the kids, there's 4 or 5 companies out there. MyoBrace is a nice company. They're an Australian-based company, but they do have American spots here in America where you can get those appliances. There's another company called Healthy Start that makes a similar appliance. So there's lots of different ways out there to get treatment. I just happen to like the tooth pillow Vivos appliance is the best.
Good. All right. Well, listen, we're going to finish up here. How do people, Dr. Blaine Leeds, how do people find you?
I'm not hard to find. I mean, I'm on all the socials, LinkedIn, Instagram. My website's Ask Dr. Leeds, all lowercase, DR, abbreviated for doctor, no dots or dashes or periods, askdrleeds.com. You can pre-order the book. The book is still not out. It was supposed to be out November the 30th, but we keep having publishing delays. It should be out any day. DrBlaineLeeds.com is my physical dental office site. It's don't judge me. It's under construction. We're trying to make it nicer. But that's where you can have an appointment with me. We're about to possibly open a facility in Utah where we're doing some really cool wellness type dentistry up there with Brian Ferry, my colleague who wrote the book, and another wonderful provider, Ashley Newton, who's been helping me for a long time. So, but that's how you can find me. I'm on LinkedIn, Instagram, all the socials. Come and chat with me anytime.
It's great. Amazing. You're a super busy guy. By the way, the name of the book again is What Happens When Your Child Doesn't Sleep. It's written by Dr. Blaine Leeds. Leeds is Leeds, by the way, if you're wondering about the spelling. And he co-wrote that with Brian Ferry, Ferry. And it's a good book. I'm going to pick it up. So it's not out yet. Is that what you're saying? We need, when are you guys going to get that published?
Well, like I say, it's supposed to have been out in November. So I thought surely by the end of January, but we still We still don't have, there's just a few more edits we're making on the last couple chapters.
Okay.
And Brian actually spells his name Ferre. So
Ferre, not Y. Okay, good. Thank you for that.
pronounce like you spelled it, but
yeah. Okay, that's the clarification there. Okay. Well, listen, friends, I want to just say thank you for all of you who are listening, for tuning in today to the Hamilton Review. It's been a great pleasure to have as my guest Dr. Blaine Leeds. He is a general dentist, but does a lot of stuff. In particular, he's helping people sleep, kids sleep, and moving their teeth around so they can actually have a nice smile and breathe at the same time, which is a worthy cause. So bravo, Dr. Leeds. And friends, so thank you, Dr. Leeds, for being on my show.
It is my pleasure to be here. I'll come back anytime. We can talk anytime you want.
We will do that. And friends, until next time, stay safe, stay well, and take care. Bye-bye.
You have been listening to the Hamilton Review, where kids and culture collide. Thank you for allowing us to be a part of your day. Tune in again next week on Apple Podcast. Rate and comment and tell a friend.